So actually, I stopped the last classes. We are talking about the last one is larynx, and today the rest part of the larynx, and then we start head and neck, and let's see how it goes. Can you hear me clearly?
Yes, sir.
Okay. So larynx, actually, we finished anatomy of the larynx, especially what are the cartilages of the larynx, the paired cartilages and unpaired cartilages. You have to know the name of that. Sometimes we ask in the Viva exam, as well as it sometimes come at written paper. What are the adductor and abductor muscles of the larynx? We discussed. The most important muscle for abduction is posterior cricoarytenoid muscle, and adduction is your lateral cricoarytenoid, thyroarytenoid, intraarytenoid muscles. Nerve supply of the larynx we discussed. Physiology of the larynx, most important is the passive respiration. We are talking with larynx, so space, and also cough reflex. Today is the intra-abdominal pressure actually for micturition, parturition, you know. So that is important part. And protection of the lower respiratory tract during eating and drinking. If you eat and drink, if the larynx doesn't close, if the glottis doesn't close, then there will be food particle may get in the larynx and lower airway and causing severe aspiration and cough. So this is important function of the larynx we discussed. We discussed about the hoarseness of voice. If you talk about the hoarseness, we know, always think of the vocal cord. So that any damage lesion in the vocal cord causes hoarseness of voice, because we move the vocal cords, we're talking. So like vocal cord nodule, polyp, papilloma, vocal cord cancer, or vocal cord paralysis. That is important cause of hoarseness of voice. We sometimes ask these questions in the exam, a clinical scenario. Suppose a patient about 60 years old or 65 years old patient presents with persistent hoarseness of voice. So what do you think? So any damage lesion in the vocal cord can cause hoarseness of voice. Stridor we discussed about the what is stridor? Stridor is defined as a noisy breathing due to partial airway obstruction at or below the level of larynx. So that is stridor. We usually ask this question in the exam. Tell me about paroxysmal stridor in children. Tell me about aparexual stridor in children. We discussed about the paroxysmal and aparexual stridor. We also give some clinical scenario, like a newborn baby presents with severe stridor but normal cry. What is the diagnosis? The diagnosis is Laryngomalacia. A 3 or 4 years old child presents with hoarseness of voice for a couple of years or months and years, recently developed stridor. What is the diagnosis? The diagnosis is multiple papilloma larynx. So in this way, we ask this question in the exam. A 5-6 years old child presents with high rise of temperature, difficulty eating, drinking, or dysphagia, sore throat, muffled speech, dribbling of saliva, and stridor. What is your diagnosis? So this scenario is a paroxysmal stridor. So think two DD. One is your acute epiglottitis. Another is your laryngeal diphtheria, or it can be acute retropharyngeal abscess. So these are the DD actually. But can be acute epiglottitis. We always ask this question in the exam, acute epiglottitis. It is caused by Haemophilus influenzae type B bacteria. It is more common in children, 2 to 6 years old, with severe respiratory distress, temperature. You can get an excess soft tissue neck. You will get a thumb sign, and you have to examine the patient in the ICU actually. You have to manage the patient. Patient may need intubation or tracheostomy, steroid, ceftriaxone, humidification. So these are the scenario. This is the treatment of acute epiglottitis. Okay. So we discover this now. This is the topics actually for exam, carcinoma of the larynx. We usually tell me about carcinoma larynx. We don't like ask the question like this. We ask the question with a clinical scenario in the real exam as well. Suppose a 60 years old male patient presents with persistent hoarseness of voice for say 1 year or 8 months, 9 months, and recently developed stridor. So what is your diagnosis? So classically in our country, diagnosis carcinoma larynx. Now carcinoma larynx is most commonly in male patient. Age incidence about 6 to 7 decades. mostly male than female. The male-female ratio is usually 5:1, but in our country, it can be 10 or 20:1 because hardly we get any cancer patient in female. Why? Because of smoking. In other country, the female are equally smoker than the male patient. That's why the incidence of carcinoma larynx in female patients is increasing day by day. But in our country, the women are very nice actually. They are non-smoker mostly, except in the high-fi women. So that's why the carcinoma larynx is less common in women in Bangladesh. Lots of laryngectomy I did, but I never did a single female patient. I did laryngectomy, never. So incidence is very high in male and mostly related with the smoking, alcohol, all these. Carcinoma larynx is divided into supraglottis, glottis, and subglottis. Clinically common is glottis around the globe, but in our country, supraglottic cancer is more common than glottic cancer. Presentation is very simple presentation. If it is in the glottis, patient presents with hoarse voice or hoarseness voice. If the growth in the supraglottis, then patient may present with sore throat or difficulty in swallowing. Patient may have referred pain in the ear. If the growth in the subglottis, patient may present with stridor. But eventually patient presents with hoarseness of voice and then patient come up with stridor because the growth is increasing in size. Then we ask this question in the exam, how do you classify TNM staging of the cancer larynx? Because for treatment purpose, you have to know this one. Carcinoma larynx TNM staging is usually T1, T2, T3, and T4. Early stage and late stage, you can say T1 and T2 is early stage, and T2, T3, T4 is late stage. T1 means when the growth is limited to one region, like your growth in the right vocal cord. If it is single vocal cord, then it is called T1A. It is both vocal cords, then it's T1B, but it's vocal cord. So this is T1. T2 means when the growth involves more than one subsides, like patient growth has got a little bit in the glottis as well as extension to the supraglottis part of it. So this is T2, but both vocal cords are moving. So T1, T2, vocal cords are free, they are moving. T3, when the growth involving the glottis or supraglottis, but one side is fixed. When you say E with fiber optic laryngoscopy, you see the vocal cord is fixed, it's not moving. So this is T3. And T4 means when the growth involves the cartilages, the epiglottic space, paraglottic space is T3, but when the growth involves the muscles, the cartilage, then it is T4. So this is the T staging of the cancer, and treatment of carcinoma larynx is very important for exam, for written paper as well as for your oral exam. So always think of this carcinoma larynx is early stage or late stage. If it comes early stage, T1 and T2 cancer larynx, then treatment is two options. One is either radiotherapy, or we can do a laser excision. That means transoral laser surgery in early stage laryngeal cancer, T1 and T2. If the tumor is advanced stage, there's some T3 and T4. Most of the cases, we usually do total laryngectomy operation. So for you people, only in early stage, radiotherapy or transoral laser surgery. If it's late stage, then go for radiotherapy. Or sometimes plus minus chemoradiation. And after surgery, we also sometimes we go for post-operative radiotherapy. After surgery, we go for post-operative radiotherapy after total laryngectomy. So this is the treatment protocol of carcinoma larynx. We ask this question in the clinical scenario like that. Even in the written paper, I usually ask this question. Suppose a 55 years old male patient presents with persistent hoarseness of voice. You did a fiber optic laryngoscopy and you found there is an ulcerated growth or there is an ulcer in the right vocal cord. And you got a biopsy by direct laryngoscopy, and the biopsy report shows squamous cell carcinoma. Okay, so clinically, the patient presents with persistent hoarseness for 1 year or 6 months, 8 months on indirect laryngoscopic examination or on fiber optic laryngoscopy. You found a growth or ulcer in the right vocal cord. Okay, and you got a biopsy, and biopsy shows squamous cell carcinoma. Now tell me, what is the T staging of this tumor? What is the T staging of this tumor? So this is a classical T1A glottic cancer. This is classical T1A because it is involved the one vocal cord. So T1A glottic cancer. Now, what is the treatment? In this case, my treatment is two options. One is either I can go for radiotherapy or oblique, or I can go for transoral laser surgery. That means endolaryngeal surgery. We can excise the growth with 5 millimeter or 5 millimeter, usually 5 millimeter surgical margin. And this is called transoral laser surgery. So equally, they're effective. Another scenario, suppose a 55 years old male patient presents with persistent hoarseness of voice. On indirect laryngoscopy examination, we found the left hemilarynx is fixed. There is a growth in the left vocal cord, but on is okay now?
Yes, sir. ठीक है, sir.
Okay. So this is T3N0. I think this the problem is going on. I don't know what happened. So this is T3 Carcinoma Larynx. You can go for radiotherapy or you can go for total laryngectomy operation. Then another question, after total laryngectomy, how do we speak? How do we speak after total laryngectomy? So there are voice restoration after total laryngectomy. One is your esophageal voice. Another is your fistula voice or with Bloom-Stinger valve. Another is your electrolarynx. These are the questions related to the carcinoma larynx. Next is, so all about carcinoma larynx, your TNM staging, you know, what are the different types of presentation, carcinoma larynx. So describe about that. It's not a big deal. Now, another topic is tracheostomy. This is very important for exam. Very, very important for exam is tracheostomy, both written paper as well as oral paper. Now, how to define tracheostomy? So tracheostomy is defined as an operation to make an incision on the anterior wall of the trachea and converting this incision into a stoma onto the skin surface. So that is a tracheostomy. Or you can say, so it is an artificially made fistula between the anterior wall of the trachea and the skin. So this is tracheostomy. It's an operation to make an incision on the anterior wall of the trachea and converting this incision into a stoma onto the skin surface. That is the definition of tracheostomy. Now, tracheostomy may be emergency tracheostomy, maybe elective, maybe permanent tracheostomy. Alexander the Great, he did the first tracheostomy in Warfield. What are the aims of tracheostomy? This question very frequently asked in the exam. Aims of tracheostomy usually just to bypass the upper airway obstruction, like indication like a carcinoma larynx, acute epiglottitis, laryngeal diphtheria, foreign body in the larynx. So any problem when we can, or laryngotracheal bronchitis or croups, these are the indication of tracheostomy to bypass the upper airway obstruction. Classically in our country is a carcinoma larynx. In any emergency laryngeal edema or fractured larynx or rotor accident, we can go for tracheostomy to bypass the upper airway obstruction. Then number 2 indication or aims is to assist ventilation. In case of patients with respiratory failure or the patient those who need ICU support, brain edema, coma patient, cerebrovascular accident patient, Guillain-Barré syndrome patient, or any of the patient, those who have a respiratory failure or respiratory paralysis, or those who need ventilatory support, like nowadays a corona patient even, we can go for tracheostomy. Or the patient, those who are in long-term intubation, they can need tracheostomy. So ventilatory support is another important indication and aims of tracheostomy. Number 2. Number 3, for tracheobronchial toileting, we can also go for tracheostomy, like in case of a lung abscess or bronchiectasis, to reduce to suck out the secretion from the lungs. We can also go for tracheostomy. Number 3 indication. Number 4 indication is to prevent the lower respiratory tract in major head neck surgery. It's called elective tracheostomy. Electively we can do a tracheostomy, and then after operation we can close the stomach. So this is an elective tracheostomy to reduce to protect the lower respiratory tract. And number 4 aims is to reduce the anatomical dead space. So these are the indication of tracheostomy and the aims. As you know, the procedure is we usually give a vertical incision or horizontal incision, usually horizontal, between the Adam's apple and the suprasternal nose. In between this, we make a transverse incision. Then after elevating the flaps and the strap muscles, we can retract the strap muscles laterally, and we can get the isthmus of the thyroid gland. We can retract the isthmus above, or we can clamp the isthmus and cut it, and then we will get a second, third, and fourth tracheal ring. Here we can make a window and we do the tracheostomy. Complication is usually classical complication is your bleeding or hemorrhage. We can have subcutaneous emphysema or surgical emphysema. This is a classical complication of tracheostomy. We can also have wound infection. We can injure the esophagus. We can injure the ligament nerve actually even. But the classical complication is bleeding and surgical emphysema. So that is all about tracheostomy. Now, then next question is we usually ask this in the exam, how to manage a tracheostomy patient. So in these 3 subheading, care of the patient, care of the wound, and care of the tracheostomy tube. So care of the patient means the patient after tracheostomy patient is unable to speak. So you have to give a propped up position. You have to give a piece of paper and pen to write something. You have to give a calling bell to draw the attention. So this is all about, and also adequate nutrition, intravenous fluid sometimes. These are the care of the patient. Care of the wounds means you have to take care of the wounds. If there's any hematoma or any infection, you have to carry it out. And care of the tube means if the tube is blocked, if you use metallic tube, then you have to take it out and put another, just clean it and then reinsert it. So if it's a plastic tube, you have to cuffed, non-cuffed. Cuffed tube usually you have to deflate the cuff every 25 minutes or 30 minutes and then inflate. So care of the tube like that. So this is very 3 short headline: care of the patient, care of the wound, and care of the tube. That is all about management. Complication of tracheostomy we discussed. So this is all about tracheostomy. And never forget, tracheostomy is a mandatory exam. Topics. That is the very hot topics for exam. Regarding the head and neck, actually, there are lots of things, but in your real exam, we hardly ask few questions only from head and neck. You don't need to make a big things or big deal. The first thing is neck swelling. Invariably, we ask this question in the exam, written paper as well as oral exam. Classify neck swelling, or tell me about some midline neck swelling. So what are the midline neck swelling? Starting from above and down, you can see there is a sublingual dermoid cyst, sublingual plunging granula here, and here is this level is a thyroglossal cyst, thyroglossal duct cyst. Then you have prelaryngeal, pretracheal lymph nodes, and then further down here is your isthmus swelling. That means thyroid swelling at isthmus. So midline neck swelling are the following. One is sublingual dermoid cyst, plunging ranula, then prelaryngeal, pretracheal lymph nodes, then thyroglossal cyst, and thyroid swelling at isthmus. These are the midline neck swelling. Now, we asked this question this time in the exam. Suppose a patient presents with a midline neck swelling, which moves on degradation. So what are the DD? The DD are many midline neck swelling which moves on degradation. Number one DD is your thyroid swelling at isthmus. Number two DD is your thyroglossal cyst. Number three is your prelaryngeal or pretracheal lymph nodes. They can also move on degradation at the midline section. Others are sublingual dermoid cyst, plunging ranula. These are the midline neck swelling. The lateral neck swelling, starting from here, any cervical lymph nodes along this level 1, 2, 3, 4, 5, all this level. So cervical lymph nodes. Here there's very cystic swelling during present at birth, or sometimes very soft fluctuant cystic swelling here. This is a cystic hygroma. Then a swelling around the endotriangle here, a cystic swelling around the endotriangle is called branchial cyst. A pulsatile swelling around this level is a carotid body tumor, or any other swelling here is a schwannoma, or lateral swelling is your parotid swelling, submandibular gland here in the submandibular region, submandibular gland, parotid swelling here, or you can have other swelling like a thyroid swelling at lateral lobe. So these are all lateral neck swelling. Now, regarding the submandibular swelling, we usually ask this question in the exam. Suppose a 25 years old male patient presents with the swelling in the submandibular region, and the patient noticed that every time he eats and drinks, the swelling increases in size and then go off. Again, when he eats and drinks, the swelling increases in size with pain. What is your diagnosis? So my diagnosis is a stone in the submandibular duct or in the just gland. So this is called stone in the submandibular duct, or sometimes in the deep part of the gland. This is called silolithiasis. Every time he eats and drinks, the swelling increases in size in the submandibular region. So one is silolithiasis. Another swelling doesn't relate with the eating and drinking, but the patient has a gradual swelling in the submandibular region. So this may be a submandibular sialoadenitis or tumor of the submandibular gland, like pleomorphic adenoma or adenocytic carcinoma of the submandibular gland. So this may be a submandibular gland swelling, a stone, or even silolithiasis or silactisis. So this is all about salivary gland tumor. Now, regarding this silolithiasis, what is the treatment? Treatment is, if it is stone in the submandibular duct, we can take it out perorally. But if the stone is within the gland, we usually excise the submandibular gland. Next question is, after excision of the submandibular gland, there are three nerves at risk. What are those nerves? So these nerves are your marginal mandibular branch of the facial nerve, it's a lingual nerve, and your hypoglossal nerve. So this is all about submandibular swelling. Okay, next is your parotid swelling. Now the patient may present with a painless lump in the preauricular region here, or subauricular region, slowly growing, firm in consistency. Usually classical swelling is your pleomorphic adenoma or mixed parotid tumor. Then maybe some other tumor in the parotid region, maybe parotid cancer, like adenocarcinoma, adenocytic carcinoma, mucoepidermoid carcinoma. So these are the cancer of the parotid region. The treatment is your, in case of pleomorphic adenoma, the treatment is your superficial parotidiectomy operation. In case of cancer, patient may need total parotidiectomy operation, but here is the main nerve at risk is your facial nerve. So complication of parotid surgery, there are two important complications. One is your injury to facial nerve, another is your phase syndrome. So these are the two important complications. Parotid swelling, there is some other swelling which can simulate parotid swelling, like your pseudoparotid, like your intraparotid lymph node, like your aneurysm of the social temporal artery, mesenteric muscle hypertrophy. This can also simulate a parotid swelling. Now, regarding thyroglossal cyst, this question asked very frequently in the exam. Suppose a 5 years old or 6 years old child presents with midline neck swelling, which moves on deglutition and which also moves on protrusion of tongue. So what is the diagnosis? So swelling which moves on deglutition as well as moves on protrusion of tongue. This is thyroglosal cyst. Thyroglosal cyst. Now, what are the investigations you want to do with this neck swelling? So I used to do a ultrasonogram of thyroid gland to see the normal position of the thyroid gland. You can also get a cystic swelling. Treatment is your cyst trunk operation, SIS, cyst, TRUNK, cyst trunk operation. This is actually the according to the name of the cyst trunk junior American surgeon. So cyst trunk operation means excision of the cyst along with the body of the central part of body of the hyoid bone and some part of the cup of your trunk tissue or core of trunk tissue. So this is a cyst trunk operation, excision of the cyst along with body of the hyoid bone. Why? Because to prevent recurrence. So that is thyroglosal cyst. What are the branchial cyst? The branchial cyst actually, there is a spelling mistake here. Is a branchial. Okay. So branchial cyst actually how this presents? Suppose a 35 years old male patient presents with a cystic or a firm swelling or swelling in the intertriangle of the neck here for say 6 weeks with slightly tender or pain. On examination, he found a swelling, a circular swelling in the intertriangle, which is slightly tender, firm and tender. What is the diagnosis? So diagnosis is sudden onset, the branchial cyst. So branchial cyst actually, it can appear anytime, the sudden onset of a swelling in the intertriangle. So that is branchial cyst. If the swelling is very much pulsatile, then it can be a carotid body tumor. What about the other? So what is the investigation of branchial cyst? So my diagnosis is branchial cyst. I used to like to do a ultrasonogram of the neck. We can get clear view of the cystic swelling. And then we can also go for FNAC, fine needle aspiration cytology. We can get a FNAC and we will confirm the diagnosis. But classically, clinical diagnosis is the most important part. How to treat this patient? Excision of the branchial cyst, excision of the cyst. Next is your cystic hygroma. We asked this question in the exam. Sir, a 5 years old child actually, or 10 years old child presents with a huge swelling in the submandibular region, which is very soft, fluctuant, and on elimination test is a brilliantly translucent. So these are all features of cystic hygroma. Brilliantly translucent is cystic swelling, soft fluctuant swelling. So this is cystic hygroma. What are the DD? The DD of cystic hygroma can be hemangioma. So cystic hygroma treatment is excision of the thorough excision of the cyst. Another name is lymphangioma. So this is all about head and neck swelling, which is commonly asked in the exam. So don't forget midline neck swelling, lateral neck swelling, or any swelling in the it can be cervical lymph node. So any swelling in the neck region actually, what are the common protocol for investigation for any swelling? So common protocol investigation actually, the first thing is you can do an ultrasonograph of the neck to give lots of idea. It can be nature of the swelling, a thyroid swelling or extrathyroid swelling, is solid or cystic, or is there a regional lymph nodes or not. So this is ultrasonogram number 1. Number 2, if any lump and bumps in the head and neck, we can get a FNAC. Fine needle aspiration cytology give a clear-cut idea about many things. Number 2. Number 3 is your hematological investigation like your blood count. In case of lymphoma, leukemia, or in other case, you can get abnormal blood count. So blood count is important. Then related to the other investigation you can do. Suppose you suspect a tuberculosis, or it can be a lymphoma, any lymph node swelling, any lymph node swelling, there are classical 3 diagnoses. One is your tuberculosis in our country, TB limb Number 2 is lymphoma, and number 3 is your metastatic lymph node. So these are the common. Now, sometimes you can also go for excision and biopsy of the lymph nodes. So that is the investigation protocol for any swelling. Next is your thyroid swelling. So what do you ask thyroid swelling in the exam? Written paper as well as oral exam. What is goiter? Goiter means any swelling. Enlargement of the thyroid gland is called goiter. As you know, the thyroid gland 25 gram. So when it's enlarged in size or is visible, then it's called goiter. So goiter is any enlargement of the thyroid gland which is visible is called goiter. Now, classification of goiter, we usually classify the goiter in simple goiter. That means the simple goiter may be simple diffuse goiter, like in case of pregnancy, puberty, or iodine deficiency area, you're going to get a diffuse goiter. Or it can be single nodule involving the one nodule, it's colloid goiter, one nodule, or it can be multinodular goiter. So simple goiter may be diffuse hyperplastic goiter, or it can be a single nodule, or it can be multiple nodule. So this is simple goiter, number one. Number two is a toxic goiter. Again, toxic goiter may be diffuse toxic goiter, like a primary thyrotoxicosis or Graves' disease. And then can be a toxic nodule. Maybe a single nodule can be autonomously toxic, or it can be multinodular toxic goiter. So toxic goiter, three types. One is diffuse toxic goiter, maybe single solitary toxic goiter, or maybe multinodular goiter or toxic nodular goiter. Number two classification. So one is simple, number two is toxic. Then number three is neoplastic goiter. Neoplastic goiter is a tumor of the thyroid gland. A benign is your follicular adenoma or thyroid adenoma, and malignant thyroid swelling. It's a very classical example in the real exam. You frequently ask this question: classify thyroid cancer, or what are the common thyroid cancer? So number one, among the malignant thyroid tumor or neoplastic goiter, malignant number one is papillary carcinoma thyroid gland. Nowadays, is about 80 to 90% is papillary carcinoma thyroid gland. Papillary carcinoma thyroid gland. Initially, it was 60% is papillary, but nowadays the cancer rate is very high. So papillary carcinoma thyroid gland. Number two, follicular carcinoma. Number three, medullary carcinoma thyroid gland. Follicular carcinoma, papillary carcinoma and follicular carcinoma, they are arising from the follicular cells, thyroid follicular cells, and medullary carcinoma thyroid gland, they are coming from the parafollicular cells. And another is anaplastic carcinoma. So these are the four main types. Other can be lymphoma. Okay, these are the common thyroid cancer. The classical is papillary carcinoma about 80 to 90%, then follicular carcinoma about 10%, medullary carcinoma usually of 3%. Anaplastic carcinoma is also 1% or 2%. So these are the classification of the neoplastic goiter. Then other goiter is inflammatory or thyroiditis. It can be autoimmune thyroiditis, can be lymphocytic thyroiditis or Hashimoto's disease, can be subacute thyroiditis like de Quervain syndrome. So these are the thyroiditis, inflammatory lesion. And then miscellaneous, like it can be tuberculous goiter or lymphoma. So these are the different types of goiter. Now, suppose a patient has got thyroid swelling. What are the common investigation for thyroid swelling? This question asked in the exam very frequently. We usually ask this question in the Viva exam. A patient has come with thyroid swelling. What are the common investigation? So, in this regard, any thyroid swelling, classically there are three investigations. Don't forget these three investigations. Number one is ultrasonogram of the thyroid gland. Ultrasound of thyroid gland give lots of information. Number one, either the thyroid swelling or involving the one lobe or both lobe or isthmus. So site of lesion. Ultrasound gives site of lesion. Number one is either involving the one lobe or both lobes or isthmus. So that is one. Number two, the size of the nodule. Ultrasound gives size of the nodule is important for cancer patient monitoring. Either what size it is, because high risk group usually more than 4 centimeter, low risk group up to 4 centimeter. That's why we have to importantly to know the size of the tumor. So ultrasound give site of lesion, unilateral, bilateral, isthmus. Number two is size of the nodule. Ultrasound give. Number three, you can give either the nodule is cystic or solid. Solid nodule has more chance of cancer than the cystic nodule. Number three. Number four, it is single nodule or multiple nodule. This is important. Single nodule or multiple nodule. Number four. Number five, is it there is any regional lymph node enlargement? Thyroid swelling with regional lymph node enlargement, always suspicious of cancer. Then number six is there any microcalcification or any heterogeneity? So many information we can get from simple ultrasonogram. So number one investigation, ultrasonogram. Number two investigation is your functional status of the thyroid gland. Like patient is hyperthyroid, hypothyroid or euthyroid. That's why patient you can get a T3, T4 TSAs, 3 investigation. But if a one investigation, hormone investigation, that is thyroid stimulating hormone, TSAs. I only do TSAs. T3, free T3, free T4, TSAs, better, but single most TSAs is important, TSAs. And number 3 is your, just don't forget this one, FNAC, fine needle aspiration cytology, FNAC. So these are the classical 3 investigation for your thyroid swelling. But other investigation, like if the patient has a huge thyroid, you're going to get a X-ray neck lateral view to see the tracheal position. If the patient is toxic, you can get some, or thyroid auto antibodies. These are the other investigation, thyroglobulin, but these are not that much essential. But 3 investigation is essential. Next is about multinuclear goiter. Suppose a patient has got thyroid swelling and T3 to TSA is normal, so it is euthyroid. What is your plan of treatment? Sir, if the patient has got solitary thyroid nodule in one lobe, then I'll go for hemithyroidectomy operation. One is if they're involving the right lobe or left lobe, so we'll go for hemithyroidectomy operation or lobectomy operation. What is hemithyroidectomy? What is lobectomy? Hemithyroidectomy means excision of the one lobe along with the isthmus. That is hemithyroidectomy. What is lobectomy? Same, sir. Lobectomy also means excision of the lobe with isthmus. Because any thyroid surgery, we have to include isthmus. Without isthmus, no thyroid surgery is not complete. Many of the surgeons, they do clumpectomy. That means nodulectomy. Just take the nodule, clamp this one and excise this one. This is not a surgery. This is not thyroid surgery. You have to, for thyroid surgery, you have to classically address the whole lobe. You have to address the parathyroid gland. You have to address the recumbent nerve. You have to trace it, you have to find it, you have to preserve it, and then excise this one along with the isthmus. You have to expose the tracheal wall. So that is the thyroid surgery. So, sir, so in case of multinuclear goiter involving one lobe, we go for hemithyroidectomy. Suppose the multinuclear goiter involving both lobes and isthmus, so we will go for near total or total thyroidectomy operation. So that is about multinuclear goiter. But can we wait and see? Yes, sir. If the FNAC is normal, if the FNAC is multinuclear goiter, we can also wait. If the patient doesn't have any pressure symptoms, if cosmetically the patient doesn't bother, then we can wait and see, sir. We can wait and see, no problem. We don't need to do operation on all patients. For the toxic nodule, sir, toxic nodule or hypothyroidism, if the TSH level is very high, this is hypo. If the TSH level is low, below 0.3, this is toxic. So we have to treat accordingly, sir. If it is hypothyroid, we have to give thyroxine supplement. And if it is hyperthyroid, then we have to give a carbizole tablet and also Indiva tablet to make it euthyroid. After euthyroid, then you can consider the operation. Next is carcinoma thyroid. So that is all about the carcinoma thyroid. Now, what is the treatment of carcinoma thyroid? So it depends on the is it low risk group or high risk group. Suppose a patient has got solitary thyroid nodule in one lobe, no lymph node metastasis, young patient, this is low risk group. FNAC shows papillary carcinoma thyroid. So this is low risk group. Now, how to treat this patient? We ask this question in the exam. Suppose a 25 years old female patient presents with a solitary thyroid nodule in the right lobe. Okay. Ultrasonogram shows a 2.5 centimeter nodule in the right lobe. Okay. Ultrasonogram shows 2.5 centimeter nodule in the right lobe. There is no lymphatic metastasis. Clinical examination shows there is solitary nodule in the right lobe, no lymph node metastasis. Okay. Then FNAC shows papillary carcinoma thyroid. Tell me, is it low risk group or high risk group? Sir, as there is no lymph node metastasis, as the tumor is very small, about 2.5 centimeter up to 4 centimeter, and it's one lobe, so this is low risk group. Then what is your treatment plan for this patient? Sir, this patient actually, I would like to do right-sided hemithyroidectomy operation, followed by thyroxine supplement to keep the TSH level about 1, 2, or 1.5. So this is low risk group. Does this patient need any radiation ablation? No, sir. The low risk group, no need. So only hemithyroidectomy followed by TSH suppression. That's it, sir. We don't need any ablation. We don't need any radioiodine ablation. Just we'll keep an eye and follow up. Suppose a patient has got a 35 years old female patient or male patient presents with two lateral swelling in the neck. One swelling moves on deglutition. Another swelling beside this one is a bit fixed, not moves on deglutition. What do you think? So the patient presents with two swelling. One swelling is in the thyroid, which moves on deglutition. Other swelling beside this a bit fixed, doesn't move on deglutition. What do you think, sir? This is a classical case of papillary carcinoma of thyroid gland. Because this swelling which moves on deglutition is thyroid swelling, and beside this is a lymph node. So any swelling with lymph node, most likely this is a case of papillary carcinoma of thyroid gland. So how to investigate, sir, this patient? I need a FNSC or routine checkup for ultrasonography of thyroid gland and neck, and then go for FNSC. FNSC will show a metastatic papillary carcinoma. And we can also go for TSH level. Now, what is your plan, treatment plan? Is it low risk group or high risk group? Sir, this is a high risk group because the patient has got cervical lymph node metastasis. Now, what is the treatment plan? Sir, in this patient, I will go for total thyroidectomy operation plus neck dissection. Usually, we address level 2, 3, and 4 neck dissection, total thyroidectomy and neck dissection, followed by radioiodine ablation, and followed by lifelong thyroxine supplement. And in this level, this high risk group level, we have to keep the TSH level about 0.1 or below. We have to keep the TSH level about 0.1 or below. So this is a classical scenario of papillary carcinoma thyroid with lymph node metastasis. Suppose another scenario. Suppose a 15 years old boy presents with a swelling in the thyroid region, and he also presents with the sub of the right lobe, and also he presents with a hoarseness of voice. On clinical examination, he found a 1.5 centimeter nodule in the thyroid lobe, and FOL shows right-sided fixed vocal cord. What is your plan? What do you think? So this is a case of, it can be a case of papillary carcinoma thyroid with invasion of the declinal nerve. Is it low risk group or high risk group? Sir, this is a high risk group because it invades the extra thyroid tissue. That means it invades the declinal nerve. So in these cases, do you want to do hemithyroid or total thyroid? Sir, this is a high risk group. So I have to go for total thyroid operation. We try to preserve the declinal nerve. Okay, so this is a high risk group. So these are the different scenarios we usually discuss. So another scenario. Suppose a patient has got solid thyroid nodule in the right lobe. Okay. FNSC shows multinodular goiter. And we did the operation. We did hemithyroidectomy operation. The tumor size is about 2.5 centimeter. Multinodular goiter. After operation, after biopsy, it came out as a papillary carcinoma thyroid. What is your next plan? Sir, yes, this is a 2.5 centimeter nodule in the right lobe, no lymph node metastasis. So as the hemithyroidectomy is done, so even the cancer report is cancer, but I don't want to do anything more because in low risk group, classical treatment is hemithyroidectomy operation. So we don't need to do anything. We don't need to completion surgery. We only follow up. Another scenario, suppose a patient has got thyroid swelling in the right lobe. FNSC shows multinodular goiter, and you did a hemithyroidectomy operation. Ultrasound shows a 4.5 centimeter nodule in the right lobe. You did hemithyroidectomy, and the report came out as a papillary carcinoma thyroid. What is your next plan? Sir, in this patient, as the tumor size is above 4 centimeter, so I did only hemithyroidectomy. Sir, this time, I will go for a completion thyroidectomy operation. That means I'll remove the other lobes, followed by, you can also use radioiodine ablation and lifelong thyroid supplement. Even suppose the patient has got 2.5 centimeter nodule in the right or left lobe, but lymph node metastasis as well. So this is high risk group. So this group of patient needs total thyroidectomy followed by radioiodine ablation and thyroid supplement. So this is all about thyroid. Now, next is a complication of thyroid surgery. What are the common complications during surgery? We can have a hemorrhage or hematoma, tension hematoma, patient have primary hemorrhage, we can injure the recurrent laryngomalacia nerve. If one side injured, patient may have hoarse voice. If two sides injury, patient may have a stridor. Patient may have injury to the esophagus. Patient may have wound hematoma, wound seroma, wound infection, keloid scar. So all these complications of thyroid surgery. Now we ask this question in the exam. Suppose a patient has got total thyroidectomy operation. After operation, the patient develops severe respiratory distress or stridor. How do you think? Sir, as the patient has got total thyroid surgery or total thyroidectomy operation and now got stridor, so there are two possibilities. One is patient might have a tension hematoma or wound hematoma that's pressing the trachea and causes stridor, or patient may have bilateral vocal cord paralysis causing stridor. Then how do you understand clinically? Sir, on examination of the patient, if I found the neck is flat, no hipped up neck, no swollen, then it is bilateral vocal cord paralysis. But if I found the neck is hipped up, huge hematoma, then it is tension hematoma. So just look at the neck actually. Is a flat, bilateral vocal cord paralysis. If it is a huge swelling, it is hematoma. How do you treat this patient? Well, sir, in case of hematoma, I have to cut the stitches off. I have to drain the blood clot, send blood for group cross mass, and ask the anesthetist to re-intubate and ligate the blood vessels. But if it is flat, if it is a vocal cord paralysis, then patient may need tracheostomy, and then we can go for other operation. So these are the complications. These are the clinical scenario. These are the clinical questions we usually ask in the exam. So I think I am able to cover actually all the topics very quickly, but these are the topics asked in the exam. If you have a look to this video in later time, I mean, when before exam, before Viva exam, you just have a quick look to this video. I think you'll get lots of, it will give lots of help to you. So I think my time is finished now, and I think this is the last class of my Viva topics. If there is anything, any new things coming up, we'll let you know. So goodbye and have a good luck for your exam. And be safe and stay safe. Thank you very much for watching.
Thank you, sir. Assalamu alaikum, sir.
So thank you very much and best of luck. Actually, if anything, new things coming up, I'll let you know. And if you have any query or any necessary, any necessity, you know, or any help you want to ask from me, I can help. No problem. I'm always side to you anytime. Okay.
Yes, sir.